It's my pleasure to introduce the first panel session of the conference. And in the interests of positive energy, we're going to use the topic of Imagine an Equitable World. I recently spoke to a conference in Singapore and was asked to articulate my vision for New Zealand healthcare. It was pretty simple. It will be a health system where all inequities had been addressed so that all New Zealanders had easy access to the right healthcare at the right time. Nothing like shooting for the stars, is there? It's an ambitious goal, but one that we should always strive for. And without further ado, I would like to introduce your panel. We have, first up, to my left, Nina Scott. Nina is a public health physician who's been involved in Māori cancer control since 2001, and she's chair of the National Māori Cancer Leadership Group. So welcome, Nina. Beside her we have Rhys Tapsell, Dr. Rhys Tapsell, who amongst a number of other roles is the Executive Clinical Director of the Midland Regional Forensic Psychiatric Services. Beside him we have Dr. Kyle Eggleton, a GP working for an iwi health provider in Northland and a senior lecturer at the University of Auckland. Kyle has a special interest in equity issues. And last but not least is my good friend and colleague Sharon Hanson, who is a nurse practitioner, one of the first to work in rural primary healthcare and chair of the New Zealand Rural General Practice Network. So I welcome you all to our conference, and I'd like to begin by suggesting that I hand over to Nina first. This session will be run on the basis of a series of presentations of Their Perfect World, and then we will follow that with a Q&A session. So thank you, Nina.
Tēnā koutou, tēnā rā tātou katoa. Ngā mihi mahana mō te wiki o te reo Māori. Warm greetings for the Māori Language Week. I have a presentation, if you could put that up. Oh, there we go. So, first of all, what are inequities? So, inequities are pretty good because they're fixable and they show us where we need to take action. We need to assume that inequities occur at every step of every pathway unless proven otherwise. And we haven't got enough research in this area. There's a bit of a myth around that actually we've got too much research, but we really don't, especially along care pathways. So how do inequities happen? Inequities in determinants of health. So eliminating poverty will not eliminate inequities because the richest Māori has a life expectancy that's lower than the poorest New Zealand European. So poverty is an important determinant of inequities, but it's not the only determinant. Healthcare access, we've heard a bit about that. But healthcare quality, that's not so well known. We have inequities in what happens once we get our foot in the door. And there needs to be more research in that area. That little tiny access to medications, if we had equity, that's from an old BPAC article, then those green lines would be skinny. So it shows that Māori have lower access to cardiovascular preventative medicines, lower access to most medications apart from acute management type things down the bottom. So we need to look at the data and compare between Māori and non-Māori to show what can be achieved at a minimum for Māori within our current systems. And I think inequities highlight where we need to standardise care first, and standardising care along places where there are inequities will achieve the dual goals of achieving equity and improving total population health gains. We talk about inequities in various ways, sometimes victim blaming, sometimes scientific, and the scientific approach is more a systems approach like the aeronautical industry uses. You look for the cause of the cause of the cause until you can find an issue that can be addressed at the systems level. We don't blame the culture of the minority group. So we've achieved equity where we have standardised care. And I was just looking this morning at the hospital advice to quit for smokers. So for my DHB, we failed the last quarter, 94%, and for the last month. But that was for the total population data. We've consistently achieved more for Māori for brief advice to quit. So, these health targets, they may be annoying, but they are really working from an equity perspective. We've achieved equity for treatment of screen-detected breast cancer and cervical cancer, not for non-screen detected breast cancer, because there are huge standardisation things around breast cancer treatment if it's screen detected. So equity in the ideal world, it's about equity focus right from the top. So it's about having the power to determine the question and right down to reporting by ethnicity, equal explanatory power and research and analytical power. And we can, if I'm allowed to say one thing to achieve equity, I'm going to say 3 one things. Because I have the power to determine the question. So from a high level, inaction and institutionalised racism is inaction in the face of need, and inequities are evidence of need and evidence of inaction in the face of need. We have closing gaps for mortality, for survival, life expectancy. It's gone from about 9 years to 7.3 years. So we're getting some progress, but we still have an awful lot of inaction in the face of need. So at the high level, we would eliminate institutionalised racism and have an equity focus in all that we do, right from the governance, from the government to the councils. For a medium kind of level, another one thing I'd say standardising care along care pathways where there are the greatest inequities. And for a tiny little bottom level one thing would be up-to-date cell phone numbers so we can track people. Okay, thank you.
Thank you. Kia ora tātou, katoa ke nei ki te tautoko ngā mihi kua mihia, ko tēnei te wiki o te reo Māori nā reira kia tātou, tēnā rā tātou. I am going to give you a slightly more pithy kind of a talk, which is 5 minutes of reflection from 3 perspectives. And those perspectives, and I do appreciate as I'm going to do this, that I'm pretty much talking to the experts, but I was asked to give you my view, so I'm going to. They're going to be from the perspective, first of all, of the father of children that are moving to that point where they're thinking about having their own children. The second is from the perspective of somebody that was involved in the advisory group looking at the refresh for the new, or the refresh of the health strategy, and I understand that the Minister earlier today spoke to you a little bit about that. And then the third is as a psychiatrist and as one of the authors of the epidemiology study that we did here in New Zealand. So if I were to, and from those 3 perspectives, if I were to be able to live in a world that I considered reflected equity, from the perspective of being a father with kids that are about to have their own kids, one of the things that I would want is I would want their kids and all of the friends of their kids to have access to all of the things that all of we in this room know kids need in order to kind of get a good start for their future. So I'd kind of like to have a world where kids had enough to eat, where they were kept safe, where their parents had some kind of modicum of a sense of what good parenting looked like. And if they didn't, had access to be able to find out about that and be supported to do that. And where kids would get a reasonably good education and have the best possible start for their future. Because quite apart from, that being motherhood and apple pie, and I'm sure all of you know, that is likely to be the best possible intervention for kind of making a better and more equitable world. And of course I wish that in particular for those people that are in the situation, those kids that are in the situation where they're least likely to get those things. So that's the first thing. Second thing, from the perspective of a psychiatrist and someone, as I said, who was involved in the writing of Te Rau Hinengaro, which is the big epidemiology study that we did here around mental health in New Zealand. What I would want is a world, is a health system where Māori who, particularly Māori, although actually New Zealanders in general, but particularly Māori because we know about the inequality, for Māori who are suffering one or other of the range of different mental disorders, whether they're the high prevalence disorders or the low prevalence disorders, to, when they got unwell, know that they could access appropriate care and treatment for that disorder in the place in which it best suited and fitted them, because we sure as hell know from the epidemiology study that that's not currently the case. We know, for example, that although for those Māori that suffer at least moderate, if not severe disorder, the vast majority of those actually get no access to healthcare services at all. Most of them, if they're lucky, turn to a friend, to a family member, to someone from their kind of cultural background for health advice. But very few of them get into general practice, and even fewer yet get into secondary care services, and most of those get there by way of the police. So I'd kind of like to have a world where that was turned around, where Māori actually had some sense of being connected to healthcare services and were able to kind of, like everybody else, not only access those services, but once they access them, be pretty clear that they were going to get the same kind of treatments that everybody else got. Because I think there's a reasonable amount of evidence to show that, notwithstanding the best of intention on the part of we clinicians, that's still not necessarily the case, not just in primary care, but actually in secondary care services as well. Then the third perspective, as I said, is a perspective that I have, having been on the advisory group, is simply really that equity as a concept, as an idea, is a concept and an idea that we might actually have emanating or traversing all of our health strategy, that we oughtn't to, we oughtn't to lose sight of some of the things that Nina has said and some of the things that I'm no doubt you will hear from other panel members, that inequity continues to be rife, and to be rife, right across all aspects of what we do. And I think if we're going to have a health strategy, we need to be able to hold on to the idea that that is an important thing to address in our strategy. So that's all I wanted to say. I'm happy to answer some questions a little bit later. Thanks.
Kia ora tātou. I'd just like to tautoko what has already been said before. I'm a GP, and I'm going to approach the issue of equity from a GP perspective, and I'm perhaps going to be a little bit deliberately provocative and lay down a challenge to us as a profession and to our college. I'm going to talk about equity from the perspective of equity of access, and I've already heard about how Māori have poorer access into primary care and general practice. And I'm going to take look at access in a couple of different ways. The normal way that we look at access is we look at about affordability, and we think about the cost of coming in to see the doctor, and that's what most of the studies have been done on, both nationally and internationally, is look at affordability of primary care. But I'm not going to talk about affordability. I'm going to talk about something else, which is about acceptability, and it's the acceptability of our practices. And acceptability is the degree of fit between a health provider and patient, and this really kind of indicates that health providers and patients have similar cultural or social values. And we know that there's poor acceptability, even though there hasn't been much study that's been done on it. I'm going to talk about a couple of examples. Probably the most obvious example is the annual New Zealand health surveys that are done every year, looking at various measures. And in those annual surveys, we can see that Māori have an unmet need despite adjusting for affordability issues. So it indicates a kind of unmet need for primary care. So it indicates there's something about primary care which is blocking or preventing Māori from coming into primary care. Also, another reason why there's more than just affordability, it's an issue for primary care. And I'm going to talk about the local context where I am in Northland. You might know that in Northland we introduced free under 13 care about 6 months ago. And we've just had the latest lot of data coming out looking at access since we've introduced that policy. And Pākehā children have increased access by about 13% and Māori by about 7%. So obviously there's more than just the cost that's preventing Māori from coming in to see us as GPs. And there's my own research, which I've been studying receptionists in primary care. And in my qualitative interviews with people, they talk about how they feel discriminated against in accessing primary care. So it's a very real thing. Now, Nina's already talked about racism and about institutionalised racism, and I'm going to pick up a little bit more on that. I think the thing is that we're all complicit in racism and discrimination. I know that might be challenging for us, but we are. Many years ago, I thought to myself, I'm not racist. You know, I treat everyone the same. My children have got Māori whakapapa. Surely I don't discriminate. And so I looked at my own data and I looked at how I treated Māori patients with known heart disease. And I found that I wasn't giving them statins in the same number I was giving to Pākehā patients. And I looked at that and I couldn't see any justification or reason as to why I was prescribing at lower rate. So, you know, this is something that we all have to be aware of. And there's significant challenges for us as GPs in addressing inequities. And this is really about a process of reflection and discovering unpalatable truths about ourselves. And as a profession, we need to place the elimination of inequity as a priority. And I know that the college has made some good moves recently in this area, and they've introduced cultural competency as being one of the things you have to do for MOPS points. However, I cringe at the term cultural competency, and I would challenge the college to move away from the idea of cultural competency, because how can we be competent in someone else's culture? Instead, I would suggest that we'd use the term cultural humility. Cultural humility is being not only thoughtful when dealing with another culture, which is what cultural sensitivity is, but it's also being reflective and having lifelong learning and growth. And there's also the challenge with racism at an organisational and an institutional level as well. How can we reduce inequity when a government doesn't place a priority on inequity in its health targets? We've got these health targets that we're supposed to achieve, but they're not really broken down by demographics at all, or there is a particular focus on equity on the health targets. An example is that in Northland, when the introduction of the 4 main health targets came in, cervical screening rates for Māori plummeted because it was no longer a target. So we have this inverse, this kind of like this issue of the unintended consequence that occurs whenever we have targets that aren't really focused on equity overall. And finally, I think that we need to challenge the model of care that we deliver in primary care. Expecting that our general practices will be acceptable to every demographic group is possibly a mistake. However, we can improve this, improve acceptability, and maybe we need to deliver care in different settings. Are we wedded to our practices and expecting patients to come to us? Or maybe we should go to where our most vulnerable patients are, for example, schools and community centres and WINS offices, and deliver care in that environment, and for us, the GPs, to become the vulnerable rather than our patients.
Kia ora tātou, and g'day. So I had to think about what it was to be living in an equitable world, and I allowed myself to dream a little bit. Imagine what it would look like. Imagine if a percentage of funding was targeted to where it came from, back into the rural community. Imagine if the poor were given a voice and it was listened to. Imagine if all government funding was filtered through a committee, headed by a non-denominational nun, included the Dalai Lama, children and elders from different ethnic backgrounds, a refugee boat person from Afghanistan and Syria, a climate change scientist, an animal welfare activist, and an accountant with a passion for sustainability. Imagine that the media reported rural stories without making it look like a backwater. Imagine if it were not cool to be filthy rich. If socialites lived in rural areas which didn't have broadband. Imagine if the honours list was given only to ordinary people who didn't get paid for what they were recognised for, and they did such things as deliver Meals on Wheels, take elderly people from the rural communities into their appointments, work with youth and disadvantaged other groups without being patronising. Imagine if all children were born with the expectation that they would be wanted and loved and parented by someone who wishes them every opportunity to reach their potential, that they will grow up with the values and the respect of autonomy of others, and that they would understand the consequences of their behaviour. That they would know what it feels like to jump in a clean river and build dams for cockabillies. In June 2011, the United Nations Secretary-General Ban Ki-moon said, "We will not build a just and equitable world unless we give equal weight to all three pillars of sustainable development: social, economic and environment. To sustainably reduce poverty, guarantee food and nutrition security, and provide decent employment for growing populations, we must make intelligent use of our natural capital. You cannot have an equitable world without paying attention to where the economic base of a society is, and that, in this country, is rural."
Well, I don't know about you, but I feel challenged. So I'm aware that we're really on a bit of a tight time frame, so I'm going straight to opening the floor for questions. And but I just like to say what a breadth of responses. I'm very grateful to you all for those contributions. It would seem we've already reached the perfect world already, so that's great.
Kia ora koutou, the panel. Thanks for your inspiration, and especially to you, Kyle, there. And this is not a dig at you, Sharon, or anything either, but I just think sometimes, or at you, or your tweet either, Joe, wherever you are, sometimes you have to be careful with the rural space and not stealing a space which has got massive data behind it in terms of inequity towards Māori and impoverished people. I'm not saying that there aren't those people in rural and that as well, but sometimes they try and steal the same space. They're two different but related issues, if that kind of makes sense. And Nina probably can explain that better maybe than I can, but sometimes it does come across as, sorry I'm putting you on the spot, Nina, but sometimes it does come across as, you know, that there's massive inequity between rural and there is, but there's massive inequity between Māori and non-Māori, and I think we're not trying to fight for the same space or say that yours is not important, but I think, you know, the data across the health system, not just in primary care, and that definitely supports, you know, that there's a massive problem between Māori and non-Māori, and we have to fix everything, but we also have to pick where our battles are. And, you know, sometimes you have to go where you got the greatest gains.
I would have been too polite to say that, but I'm really glad you brought it up.
I wasn't going to, but no one else is saying anything, so bugger it, I'm going to be impolite and say it.
You're brave, that's good. So it's very clear that we have inequities by ethnicity, and they're the biggest inequities that we've got in this country. And the inequities between Māori and non-Māori are the most consistent of those inequities by ethnicity. Next we have inequities by deprivation, and they're pretty huge. You can imagine the difference between living in Dep 1, where you can have servants, living in Dep 10, where you have maybe 1 or 2 days a month where you don't have enough food to eat. And thirdly, there is some evidence of deprivation between rural and urban, but it's not as large as the other two inequities, and it's not as consistent.
Can I also say I think there are quite a few Māori who live in the rural sector as well.
Yep.
And so I was certainly not making a plug for rural at the expense of Māori. Not at all.
Yeah, it's quite clear that rural Māori are disadvantaged compared to urban Māori, but it's not often, I mean, for New Zealand European versus rural versus urban, sometimes there is no inequity, depending on what we're looking at.
Joe Scott Jones, I'm a GP in Apotiki, and Kyle, I was really struck by your comment about statins and Māori, and if somebody like you can identify a difference, then where do I stand, was the question. And I think the challenge to every one of us in the room is to go back and to review our outcome around that issue as an example. It'd be great if we had a simple sort of query build tool that was available, but maybe sort of that was triggered off by that issue. You talked about trigger tools yesterday, that we can all take that on board and really reflect on our practice on Monday. So thank you very much. I think that was a very brave thing to share and and inspiring. Thank you.
Thanks, Joe. I guess the thing is it's always ongoing. You know, you're always, if you're trying to have cultural humility, every interaction you have to analyse and think about your responses to that person. And it's not just for Māori as well. You have to think about how you look at people who are overweight or who have mental illness or who are different to you, because we're constantly othering others and we just need to analyse ourselves.
Hi, Julie Forsey here, GP from Lower Hutt. Looking at New Zealand on an international perspective, looking at the graphs for income inequity, where in America the richest 10% earn 8 times more than the poorest 10%. In New Zealand, the numbers are the richest earn 7 times more than the poorest. So looking at the graphs for international health outcomes, depending on the gap between the rich and poor, America comes out at the worst end of all of those graphs, and New Zealand is at the wrong end, along with Australia and the UK, for most of those issues. Does any of the panel members have any feelings about the bigger picture, what we can do to reduce those inequalities in income across the board?
Tax the rich more.
That's my response as well. It's about equal or fair, not equal, but fair taxation.
Get my committee going.
Yeah, get the Dalai Lama on board.
Can I comment, please? My name is Vivian Capel. I work at Newtown Union Health Service, and absolutely agreeing with what everybody says, but in my practice where I work, the inequities are around Pacific and mental health, and I find it very difficult when we start to carve things up and make targets according to, say, Māori or rural or whatever we make targets to, because there's always going to be some part of the population that misses out. We've just got to accept that there are inequities all over the place, and to be aware of it, I suppose. And my benchmark is to think, is the care that my patient is receiving what I would expect for myself? And if it's not, then it's probably inequitable.
Hi, Fraser Hudson. I'm a GP from Te Awamutu. Excuse my voice, I've lost it. One of the jobs I do, I'm medical officer for Waikaria Prison, which 80% our inmates are Māori. One of the jobs I do try to do is get them on statins at times, and I do sometimes have a lot of trouble convincing them that it's the right thing to do. However, we have a number of Māori nurses out there who speak te reo, and they often manage to have much more success in convincing the inmates that this is the right thing to do, which raises the point for me is how important is the workforce in terms of reaching Māori? Is it better for Māori to reach Māori? Any comments?
I think it's nice to have grow the Māori workforce, because we currently don't have representation, but even when we do, I don't think we can rely on the Māori workforce to be the answer to all of our problems, but I think it's more about developing up the non-Māori workforce. That's where our efforts need to go equally, possibly.
I would also like to say that on the whole, nurses are quite good at developing relationships from a different philosophy that patients can relate to. They do so in different environments, and they do so with different time frames, and that adds to the team in immeasurable ways. So if you're looking to develop a healthcare system that reaches out to people, you need more than doctors, you need more than nurses. We all need to work together.
I think a Māori workforce is really important, but more importantly, I think it's about values and the values that we have. I work for an iwi health provider. Not all the staff in my iwi health provider are Māori. There's me, a Pākehā, and a Thai nurse and an Indian nurse, and yet we hold certain values which I think are really important. So I think it's about values.
The other thing that I would comment about that is really just building on what Kyle said, which is that certainly in the kind of treatment context I've been involved in, that it's great to have a Māori nursing workforce, but actually as the doctor, obviously in my sphere the psychiatrist and yours the GP, as the doctor you can either really reinforce the cultural perspective on the basis of what you do, or you can undo what your Māori nurse does on the basis of what you do. So for example, just some very simple things. When we train our trainees now, we don't bother with large, complicated training programs around a wide range of quite sophisticated kind of cultural interventions. The one thing that I say to the kids that I do some training programs is just learn to pronounce Māori names properly. You don't have to speak Māori, just pronounce the names that are Māori correctly, because it actually reflects an incredible amount of engagement on your part that Māori people recognise immediately. It says so much. So I think some of those things are really simple, and it's really just building on what Kyle said, which is that the Māori workforce is great, but actually having values and having practices and behaviours that reflect those values are probably, in my view, more important.
It's like the cultural humility thing. I always remember Dr. Prabhahura and Vali Puria Nathan, and I was the only one who could say his name in the hospital. So I think it's for any culture, any name, we need to learn how to pronounce it, even if it takes 5 or 6 goes. I think people really appreciate it if you make that effort.
Hi, my name is Rao. I'm a GP in Mid Central area. I have an interesting practice mix in a town which is supposed to be rich, and the average GP has 24% high needs patients. I have 40%. I have a combination of Pākehā, I have a largest number of Maori, I have a lot of Bhutanese and Nepalese people, and a lot of Muslims. They feel comfortable with me because I have a cultural acceptance. I accept that all cultures are different. My culture is different from Pākehā, from Maori, from Muslims, and the Bhutanese, and the Buddhists. My problem is not that. It's not the cultural issue. Somebody asked me, how do you deal with Buddhists and Maori, apart from Pākehā, the rich people, the poor people? My answer to them was, I treat them all equal. I don't do anything different from Maori, I don't do anything different from Buddhists, I don't do anything different from the refugees. I treat them all in the same way. Apart from the cultural background, I have a lot of youth, a lot of teenage pregnancies. The youngest teenager I had pregnant this year is 13 and a half years. She is helpless. She doesn't know what to do, where to go. And I have a lot of high school dropouts. They don't know where to go. They have totally loss of confidence. They are depressed. And unfortunately, what I'm saying, and I might be cynical in this, I might be unique in this. But what I'm seeing is the Pakeha are catching up with Maori and the refugees. I've got a lot of Pakeha patients who come to me and say, "Doctor, can I buy this tomorrow?" I ask them, "Why? You need it today." "Oh, tomorrow is the day I get paid. I have no money." It makes me very sad. But that's the reality on the ground in quite a few practices. I personally believe I don't need to make any difference between all these races, all these youth groups. All I just need to do is look at their needs and see what I can do. Thank you.
I'm a GP from Takaroa, and I would just like to there's two areas that it seems to me we need to find out how to address more equitably, and that is the whole thing of health literacy, not just for Māori, but any disenfranchised group. And I'm well aware that if you add disability to being Māori, let alone having a disability, there's a huge area of unmet need in that area. So we need to find ways with the workforce that we have of somehow empowering the disenfranchised groups so that they're better able to access their healthcare because they'll have a better idea of what to ask for. And the other thing is that, I've forgotten the other thing because I've been waiting to talk, so I'll leave it at that.
I'm Leslie Topping and I'm from GP from Hamilton. I'd like to echo the thought about it not just being Māori and the thought that targeting groups always puts the spotlight on one lot and leaves another lot out in the dark. So if you support one lot, there's another lot that fall off the edge of the plank. And I think that's sad. But the new point I want to make is that equitable is not the same as equal. If you treat everybody exactly the same, then you are ignoring their individual differences. Evidence-based medicine is tremendously useful at government level. It's no bloody good at individual level. What we're here for is to look after people, and this person may very well need to go on to statin. That person with the same Framingham bloody score may not need to go on statin. And we are here to look after people as people, and that's what equitability is really about.
On that note, I think we shall wrap up and move on to the next session. But before we do, I'd just like to take this opportunity to thank our panellists for their time, and I appreciate you coming. Thank you.